am Anne Woolfield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound Podcast, bringing you up-to-date information in all things ONG. Today, we're talking about placenta previa. Today, we'll cover epidemiology, diagnosis, and complications, and follow it all up with a case to consolidate our knowledge in next week's episode. So let's start off with the definition. What is placenta previa?
A placenta previa refers to the presence of placental tissue that extends over the internal cervical os. Now, this is different to a low-lying placenta in which the placental edge is within 2 centimetres of the cervix. Sounds simple, right? Well, the definition hasn't always been so straightforward. Historically, placenta previa has been described as complete, partial, marginal, and low-lying, and was actually based on the extent to which the placenta could be felt through the cervix. Complete previa referred to implantation over the internal os where the margin of the placenta could not be felt. Partial previa referred to the placenta covering a closed internal os, but not completely covering a dilated os, and marginal previa meant an implantation in which the margin could be easily felt.
That is just crazy that we used to diagnose placenta previa by doing a VE, when that's literally the first thing we're taught about placenta previa nowadays. Don't poke the previa.
Well, interestingly, palpating the placenta on VE was an important way to differentiate between bleeding from placental abruption and bleeding from placenta previa. At the time, treatment of placenta previa involved rupturing the membranes, internal podalic version, and using the baby as a tamponade.
What? That is insane.
I know, right? It wasn't until 1945 that we realised that poking the previa might not be such a good idea. It seemed that every time we did it, we precipitated a massive hemorrhage. Instead, women with a bleeding previa started to be managed conservatively with blood transfusions and weren't delivered after the first major bleed.
You know, we didn't actually use ultrasound to localise the placentas until 1966, and initially the scanning was only done transabdominally. Transvaginal sonography was introduced in 1969 and has since become the gold standard for diagnosis of placenta previa. We used to use the terms grade 1 or minor placenta previa, grade 2 or marginal previa, grade 3 or partial previa, and grade 4 or complete previa based on the transabdominal scan findings. Nowadays, we describe placenta previa using a simplified classification based on the location of the placenta on transvaginal ultrasound. Placenta previa is where the placenta is covering the internal os. Low-lying placenta is where the placental edge is within 2 centimetres of the cervical os. And normal placental location is where the placental edge is greater than 2 centimetres from the os.
Well, that is much easier to remember. Now, how common is it? How often would you say we see somebody with placenta previa?
About 5% of women will have a low-lying placenta on the morphology scan, but most of these actually resolve before delivery. A persistent placenta previa occurs in about 1 in 200 pregnancies. The incidence of placenta previa is actually rising, mainly because of the increase in caesarean rates and assisted reproductive technology, which are both risk factors for the development of placenta previa.
Did you know that at one point, Australia had the second highest incidence of placenta previa in the world? A 2013 systematic review and meta-analysis on the prevalence of placenta previa by world region found an incidence of 10 in 1,000 in Australia compared to 11 in 1,000 in Asia, which was the highest at the time. The lowest rates were actually in sub-Saharan Africa at about 2 in 1,000.
All right, so let's talk about risk factors. Which groups of people are more likely to have a placenta previa?
If you had to list the 3 major risk factors for placenta previa, for example, in the Ranscoe exam, you would say previous placenta previa, previous caesarean section, and multiple pregnancy. Women with a previous placenta previa have a recurrence rate of about 4 to 8%. Previous caesarean section increases the risk by 50 to 60%, and the risk increases the more caesareans you have. So after 1 caesarean, there's a 1% incidence of previa. After 3 caesareans, there's a 2% incidence. And after 4 caesareans, you've got a 10% chance of having a placenta previa. Having a second pregnancy within 1 year of a caesarean is also considered to be an increased risk of placenta previa. Pre-labour caesarean is also thought to increase the risk of placenta previa more than if you have a caesarean in labour, which I thought was a bit surprising actually. Finally, the rate of placenta previa is 40% higher among twin births than singleton births, with dichorionic being more likely to have a placenta previa than monochorionic twins.
I guess it makes sense since there are technically 2 placentas with DCDA twins. There's only so much room for them to grow. Other risk factors for placenta previa include advanced maternal age, multiparity, previous uterine surgery, uterine artery embolization, infertility treatment, maternal smoking or cocaine use during pregnancy, and again, having a male fetus.
Boys, trouble the lot of them. So what's that now? If you have a male baby, you're more likely to have a higher chance of prolonged pregnancy, worse outcomes if the baby's born premature, and now an increased risk of placenta previa. Man, if I get pregnant, it better be a girl.
Except if with girl pregnancy, you're more likely to have hyperemesis. So,
Oh, yeah. I gotta think this through.
So, Anne, do we know why placenta previas occur?
The pathogenesis of placenta previa is currently unknown. There's a theory that suboptimally vascularized decidua in the upper uterine cavity from previous surgery, for example, might promote the implantation of the trophoblast in the lower segment, or unidirectional growth of the placenta towards the lower uterine cavity. The other theory is that a particularly large placenta increases the chance that the placenta will cover the os, like we said about twins.
Okay, so how do we actually diagnose placenta previa?
Placental location is typically assessed at the morphology scan. If a transabdominal scan shows a distance of less than 2 centimetres between the placental edge and the os, then a transvaginal scan is performed to confirm the findings. If we relied on a transabdominal scan alone for diagnosis, we would definitely overdiagnose placenta previa. The false positive rate is about 25%. The distance in millimetres that the placenta extends over the internal cervical os should also be described in the diagnostic report. Oh, and colour and pulse wave Doppler should also be used to exclude vasa previa in any cases of placenta previa or low-lying placenta. Remember, a low-lying placenta is a risk factor for vasa previa.
Now, there are a few technical considerations when scanning for a placenta previa. Firstly, you want to make sure the patient has an empty bladder. An overdistended bladder can compress the anterior lower uterine segment against the posterior segment, making it look like the patient has a placenta previa. The diagnosis of placenta previa should also not be made when the lower uterine segment is contracting, which is actually pretty common after emptying the bladder. A contraction obscures the relationship between the placental edge and the cervical os. You can suspect a contraction if the anterior and posterior myometrium adjacent to the cervix appear more thickened than normal. If you wait 15 to 20 minutes and repeat the scan, that should give enough time for any contraction to resolve. Placenta previa can also be missed near term if the fetal head is low in the pelvis because of acoustic shadowing from the fetal skull or compression of the placental tissue. In these cases, you can put the patient in Trendelenburg or gently elevate the fetal head with a transducer or hand. Posterior placenta previas are also notoriously more difficult to visualize than an anterior placenta previa.
So tell me this, why is it that we can't do a vaginal examination with placenta previa, but it's okay to use a transvaginal probe?
That is a really good question. So actually, the optimal position of the vaginal probe for visualizing the internal os is about 2 to 3 centimeters away from the cervix. The angle between the cervix and the vaginal probe is also generally enough to prevent the probe from accidentally slipping into the cervical canal. So if a transvaginal scan is done gently, the chances of disturbing a placenta previa and causing bleeding is incredibly low. This is different to a VE, where you are actively putting your finger inside the cervix and disrupting the placental interface. Still, caution should be exercised when doing any transvaginal scan.
It's also really important that you suspect a placenta previa in any patient beyond 20 weeks who presents with vaginal bleeding. Remember, if you don't know where the placenta is, don't do a vaginal examination because you can cause severe hemorrhage.
Now, back to ultrasound, we said earlier that most cases of low-lying placenta will resolve later in pregnancy. Now, typically, we would repeat the ultrasound at 32 weeks to confirm placental position. It's also important that a transvaginal scan is repeated here, regardless of the placental location, in order to exclude vasa previa. If there's a low-lying placenta or placenta previa and it persists at the 32-week scan, then another repeat scan should be done at 36 weeks gestation.
There are actually a few features on the ultrasound that can help us predict whether a low-lying placenta is likely to resolve or not, and I think this has definitely come up on some past RANSCOG exams. A posterior placenta is more likely to remain low-lying compared to an anterior placenta. The anterior uterus tends to distend more than the posterior uterus, and anterior placentas are much more likely to move towards the fundus. The lower uterine segment lengthens from 5 millimeters at 20 weeks gestation to more than 50 millimeters at term. As it lengthens, this tends to move the lower edge of the anterior placenta away from the internal os. The lower segment is also relatively less vascular than other sites of the myometrium, and so the placenta tends to prefer to go towards the fundus, which can also explain placental migration, or our new favourite word, trophotropism. Secondly, the more the placenta extends over the os, the more likely it is to persist until delivery. This is thought to be because the cervix itself is quite vascular, and so the placenta has no need to migrate to a better blood supply.
We can actually quantify the probability of a persistent previa based on the distance the placenta extends over the os. If at the morph scan the placenta is less than 14 millimeters over the internal os, the probability of placenta previa at delivery is actually nearly zero. If the placenta is between 14 and 25 millimeters over the os, the chance of a persistent previa at delivery is about 20%. And if the placenta is more than 25 millimeters over the os, the chance of a previa at delivery is about 40 to 100%. When the placenta is 55 millimeters over the os, that placenta is not going to move. There is a 100% chance of persisting previa at delivery. The presence of a caesarean scar also increases the chance of a persistent placenta previa in cases where the placenta is anterior.
All right, I'm going to mental note those numbers. Less than 14, 14 to 25, 25, and 55 millimeters.
Repetition.
We can also use ultrasound to help us predict which patients are more likely to present with antepartum hemorrhage. There are 5 ultrasound features associated with APH. A thick placental edge greater than 1 centimeter, placental extension over the cervical os, a cervical length of less than 3 centimeters at the morph scan or less than 3.5 centimeters in the third trimester, a decrease in transvaginal cervical length between the second to third trimester of more than 6 millimeters, and the presence of an echo-free space in the placental edge over the internal os. Other factors that increase the risk of antepartum hemorrhage in placenta previa include an anterior placenta, grain multiparity, and more than 3 previous intrauterine procedures.
So that brings us nicely into the next part of our episode, complications of placenta previa. By far, the most common complication of a placenta previa is bleeding. Bleeding typically occurs when uterine contractions or gradual changes in the cervix and lower uterine segment apply shearing forces to the inelastic placental attachment site. This results in partial detachment of the placenta and hence bleeding. Vaginal examination and intercourse can also disrupt this site and can cause profuse bleeding. The bleeding is typically maternal blood from the intervillous space. However, fetal bleeding can occur if fetal vessels in the terminal villi are disrupted. Bleeding occurs in up to 90% of cases of persistent placenta previa. This bleeding is typically painless, although 10 to 20% of patients will present with uterine contractions, pain, and bleeding, similar to the presentation of patients with placental abruption. So let's talk stats. And what are the numbers we need to remember?
So firstly, as you said, 90% of patients with a persistent placenta previa will present with painless vaginal bleeding. About 1/3 of patients will have their first bleed before 30 weeks, and this group are more likely to require blood transfusions, have a preterm birth, or perinatal mortality than those who start bleeding later in their pregnancy. Another 1/3 of patients will have their first bleed between 30 and 36 weeks, and the final third will have their first bleed after 36 weeks gestation. And only about 10% of patients will reach term without any bleeding.
Not only does a placenta previa increase the risk of antepartum hemorrhage, but it also increases the chances of a postpartum hemorrhage, blood transfusion, and need for hysterectomy. What are some of the other complications of placenta previa?
Malpresentation is a big one. Because the placenta previa sits in front of the presenting part, it tends to prevent the fetal head from engaging in the pelvis. As a result, there's a higher incidence of malpresentation like breech or transverse lie. Vasoprevia and velamentous umbilical cords are also associated with placenta previa and should be checked for at the morph scan, but also at every subsequent scan. Fetal growth restriction has been reported, but it remains a bit controversial. I don't think there's any clear evidence to say that an asymptomatic placenta previa definitively increases the risk of fetal growth restriction. Population studies have also reported a very small increase in the overall rate of congenital anomalies in pregnancies with placenta previa, although there doesn't seem to be one particular abnormality or syndrome that is clearly associated with the condition.
Oh, and don't forget the risk of placenta accreta spectrum. You should always consider the possibility of placenta accreta, especially in the presence of an anterior low-lying placenta and a previous caesarean section. The chance of a placenta accreta with a low-lying placenta increases depending on the number of caesarean sections. With one previous caesarean section, the risk of placenta accreta spectrum is 11%. With 2 previous caesarean sections, the risk is 40%. With 3 previous caesarean sections, the risk is 61%. And with 4 or more previous caesarean sections, the risk of placenta accreta is 67%.
These complications are super important to consider when managing a patient with placenta previa, especially when it comes time to plan for delivery and to consent for a caesarean section. So in general, what are the risks of maternal and neonatal morbidity?
As we said before, maternal morbidity from placenta previa is usually related to antepartum or postpartum hemorrhage. Because of the risk of bleeding, patients with placenta previa are more likely to receive blood transfusions and undergo peripartum hysterectomy. In high-income countries like Australia, the maternal mortality rate associated with placenta previa is very low, about 3 in 10,000. This is not the case in developing countries where maternal anemia, lack of resources, and home births are much more common. Maternal mortality is usually due to rapid, significant hemorrhage resulting in hypoxia, organ damage, and death. Mortality can also be due to amniotic fluid embolism, which has been shown to have a strong association with placenta previa.
The main causes of neonatal morbidity and mortality are related to preterm birth, neonatal anemia, and a higher risk of adverse neonatal outcome in patients with recurrent bleeding. A 2015 meta-analysis that compared cases of placenta previa with no previa showed that placenta previa was associated with a 3 to 5-fold increase in the risk of preterm birth, NICU admission, neonatal death, and perinatal death. Neonatal morbidity and mortality rates have fallen over the past few decades because of the use of antenatal corticosteroids, the push towards late preterm or early term caesarean birth, and improved neonatal care.
Okay, so that wraps up our first episode on placenta previa. Short and sweet, but it gives us the background information we'll need to manage our case next week. Let's cap off the episode with a summary. Placenta previa is the presence of placental tissue that extends over the cervical os. Low-lying placenta is where the placental edge is within 2 centimeters of the internal os.
The incidence of placenta previa is about 1 in 200 and is rising. The major risk factors for placenta previa include previous placenta previa, previous caesarean, and multiple pregnancy. Other risk factors include advanced maternal age, multiparity, infertility treatment, previous uterine surgery, previous uterine artery embolization, smoking and cocaine use, and male babies.
The pathogenesis of placenta previa is unknown, but is thought to be due to poor vascularization of the upper segment, resulting in implantation or growth of the placenta towards the lower segment. Large placentas also have an increased chance of encroaching on the os.
Placenta previa is best diagnosed on transvaginal scan, which should be done if the placenta is less than 2 centimeters from the cervical os on transabdominal scan at the morph ultrasound. This scan should be repeated at 32 weeks to confirm persistence of a placenta previa. Remember, 90% of low-lying placentas will resolve by delivery. Oh, and don't forget to screen for vasa previa in the presence of a low-lying placenta or placenta previa.
Factors that increase the chance of a persistent previa include posterior placenta, placenta extending more than 25 millimeters over the os, lack of resolution by the 3rd trimester, and presence of a uterine scar.
And ultrasound factors that increase the risk of antepartum hemorrhage include thick placental edge over 1 centimeter, placenta covering the os, cervix length less than 3 centimeters at the morph or less than 3.5 centimeters in the 3rd trimester, reduction in cervical length of greater than 6 millimeters between the 2nd and 3rd trimester, and presence of an echo-free space in the placental edge over the internal os. Non-ultrasound factors include an anterior placenta, grand multiparity, and 3 previous uterine procedures.
Bleeding is the most common complication and occurs in up to 90% of cases. 1/3 will bleed before 30 weeks, 1/3 will bleed between 30 and 36 weeks, and 1/3 will have their first bleed after 36 weeks. 10% of patients will have no bleeding at all. Additional complications include postpartum hemorrhage, blood transfusion, hysterectomy, placenta accreta spectrum, malpresentation, vasa previa and velamentous cord insertion, fetal growth restriction, maybe, and a very small increase in congenital abnormalities.
And finally, the overall maternal morbidity and mortality is due to antepartum and postpartum hemorrhage, with a death rate in high-income countries of 3 in 10,000, whereas the neonatal morbidity and mortality is mainly due to fetal anemia and preterm birth.
So that wraps up this week's episode of the Uterine Sound Podcast. Join us next week where we'll talk about how to manage pregnancies with placenta previa and low-lying placenta.
Keep an eye out for our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out on our email, theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound or our website, www.theuterinesound.com.